A very good morning to the oncologists, medical physicists, and my dear patients and the beloved family members. Thank you for giving us this opportunity to present in the CME. My team would like to talk about the treatment plan for the breast cancer. So the site for the treatment will be the left breast side. Now we will move on with the beam orientation. There will be 4 fields treated for this patient. This beam orientation is used to reduce the dose at the organ at risk. For example, the organ at risk are the ipsilateral lung, contralateral lung, heart, and spinal cord. This type of field technique is called field-in-field technique, and this technique is widely preferred method for administering tangential whole breast radiotherapy. Several studies have reported that the use of this field-in-field technique facilitates the better control of dose homogeneity. The FIF technique was reported to be useful in reducing the hot region as well as the cold region.
Hello, I'll be presenting about the patient fixation. The patient is positioned supine with anterior chest wall parallel to the couch on the breast spot. The arms overhead and comfortable. In our case, the left arm will be abducted up. The head turned to the opposite side while on the headrest. The head will be turned to the right hand side in our case because the left hand side of the breast will be irradiated. There are 2 types of devices, immobilization devices that is used in our patient positioning, which is breast spot and also knee rest. Knee rest is used for the comfortability of the patient.
Hi, so today I'm going to present on treatment volume. So treatment volume is an important aspect that should be included in treatment planning process. Based on ICRU 62, there are 6 treatment volumes that we need to include in treatment planning process. First of all will be the GTV. So GTV is a gross tumor volume where we need to include the gross demonstrable extent and location of the tumor. Next is CTV, so we must include the GTV and also subclinical microscopic malignant lesion. So in internal target volume ITV, we should compensate the changes in size, and shape of organ and tissues in CTV. So same goes to PTV, planning target volume. So we should cover the changes in beam alignment, patient positioning, organ motion and deformation. Other than that, we also need to delineate the organ at risk, the normal tissues around the treatment planning area. Lastly will be the planning organ at risk volume PRV. So the volume include the movement of OAR due to the changes in size, shape and setup uncertainties. It works exactly same like PTV compensates CTV. So this diagram shows how delineation of treatment volume occurs. So first will be GTV covered by CTV and ITV and lastly by the PTV, and we also will delineate the OAR. So according to these images, the colored region shows the treatment volumes that have been planned during the treatment planning process. So the doses will be distributed to the treatment volumes. Next part will be the ICRU reference point.
Regarding the ICRU reference point, there are several general criteria that has been listed in ICRU report 50 and 62. Those are: the dose at the point should be clinically relevant, easy to define in a clear and unambiguous way, dose should be accurately determined, and no steep dose gradient is involved. As you can see in the next slide, the circled place is the ICRU reference point that we found, which is 100%. We found it by putting it together that it's always at the center and also it's intersected by the axes. Now this is also proven because the ICRU report 50 and 62 also states the 2 recommendation, which is always at the center and also the intersection of axes is what ICRU reference point is all about. So that's how we found it.
Now I will talk about the dose distribution for this treatment plan. From the treatment planning, the maximum dose that we obtain is 107.3%, which is the red area shown on the diagram here. As we all know, the recommended maximum dose based on the ICRU report 50 is 107%, which cannot more than 7% from the actual treatment dose. However, as we can see in this treatment planning, the maximum dose is more than 0.3% from the recommended dose, which may indicate an excessive radiation to normal tissue. Based on the ICIO report 50 also, the maximum dose within the PTV should be followed, as it is important to limit the radiation dose to normal tissue while maximizing the dose to tumor volume. Controlled maximum dose can eventually help in the reduction of side effects of the treatment. The maximum dose to PTV with the area described below has to take into account for evaluating the homogeneity of the dose distribution. Now we will move on to the minimum dose. The minimum dose that we obtain from this treatment planning is 95%, which is the dark blue area shown on the diagram here. As we all know, the minimum dose from this treatment planning follow the recommended minimum dose from the ICIO report 50, which stated that the minimum dose should not be more than 5% from the actual treatment. If the doses is too low, it may cause dose inhomogeneity within the tumor volume. ICIO report 50 also stated that there were no volume limit is recommended for minimum dose, as it can reduce the radiation to organ at risk. The larger the volume of minimum dose to organ at risk, the better the organ at risk is to be protected from the radiation.
The following aspect that I will present is about the side effect. So this side effect is the common condition happen to the breast cancer patient when they undergo radiotherapy. Bear in mind that some of the patients will experience this effect and some are not. So let's find out more about this. The first side effect is the skin toxicity. The radiation dermatitis still continue to be most common side effect of radiotherapy, and acute skin reaction has a threshold development, starting with the erythema at 6 to 10 gray and become worsened at 40 gray or more. The majority of symptoms usually relieves in 2 to 4 weeks after the end of the treatment, whereas the hyperpigmentation lasts some more months. For the pulmonary toxicity, tolerance dose for lung are as follows. Mean lung dose for ipsilateral lung in range between 7 gray to 18 gray, while for the contralateral lung is from 0.1 gray to 3 gray. Only 30% volume of lung can receive 30% from the prescribed dose. Lung toxicity such as radiation pneumonitis will occur if for some patients. Incidence rate for this pneumonitis is below 10% if the mean lung dose is less than 10 gray. The radiation pneumonitis rate will increase up to 16% if the mean lung dose in the interval between 10 gray to 20 gray. For the cardiac toxicity, for patients with the radiotherapy treatment at left breast, the dose permitted to the heart is only 2 to 7 gray, whereas for the treatment for the right breast, the dose is 1.5 gray. The reason left side receive higher dose is because the anatomical position of the heart itself. When discussing about tolerance dose for the heart, we use this parameter V20 at 10% and V40 5% under the standard fractionation. The rate of cardiac toxicity will happen as follows. It is estimated that every 1 gray increase in mean heart dose, it will result in a 7.4% higher rate of majority coronary events to happen, such as myocardial infarction and a death from ischemic heart disease. Next is the radiation plexopathy. Patient will feel painless numbness and sensory symptoms, which affect mostly on the upper limb. To manage this effect, some education program can be delivered to the patient. Radiotherapists can ask patients to do some simple home exercise program, just like the simple hand stretching, to preserve the strength of the shoulder and arm motion. The following is the secondary cancer risk. The risk of contralateral breast cancer depends on the several factors such as hormonal and the genetics, while the radiotherapy seems to have a role in improving the risk only in the young woman if irradiated on the internal breast quadrant. That's all from us in this CME, so thank you.